Bismillahirrahmanirrahim. This is a female patient who presented with a history of severe headache and diplopia, while she also had a history of progressive visual loss. When her eye examination was done, she had papilledema on both sides. Here is her MR examination of the brain. We have axial T2 weighted sequence. We can see optic nerve on both sides, and increased CSF sleeves are noted on both sides, while we can also see there is CSF in pituitary fossa because of partial empty sella. And this is sagittal T1 weighted sequence of the brain, and we can see herniated CSF in pituitary fossa suggesting partial empty sella. So this is a case of benign intracranial hypertension who presents with severe headache with increased CSF pressure, which can be confirmed through lumbar puncture, where opening CSF pressure can be more than 200 millimeter of mercury. Fundoscopy shows papilledema, and patient usually presents with transient or progressive decrease in the vision. Initially it was termed as pseudotumor cerebri, but now it is called as idiopathic intracranial hypertension. Patients are usually young obese females with papilledema, and sometimes they present with a history of vitamin A toxicity and their derivatives, sometimes oral contraceptives, steroids, and tetracyclines. And such patients presents with a history of diplopia and sometimes with cranial nerve palsies and elevated opening CSF pressure on the lumbar puncture, as we have discussed. For treatment purposes, we need to stop offending medicines, and our target is to lower CSF production with the help of acetazolamide and furosemide. Patient can be given steroids as well, while repeated lumbar punctures can be used to reduce CSF pressures. And sometimes the patient are given the choice to have a ventricular shunt if impending visual loss. Whenever such patients come, we need to check patency and the caliber of dural venous sinuses. Here there is an example where we are unable to see, or we couldn't get normal left-sided transverse and sigmoid sinus. This can be seen on axial images as well. So this is a case of dural venous sinus thrombosis. Here is an example of hypoplasia of the dural venous sinuses, where there is decreased caliber of dural venous sinuses. So these two causes can lead to benign intracranial hypertension. We have to check associated findings with idiopathic intracranial hypertension, which includes adrenal insufficiency or Cushing disease, hypoparathyroidism, hypothyroidism, and excessive thyroxine replacement in the children. Sometimes chronic renal failure and SLE can be seen in association with benign intracranial hypertension.